Welcome to the Beacon Point conference call today. Today's topic is navigating coronavirus and the markets. Thank you very much for attending. My name is Michael Dow. I'm the CIO at Beacon Point. And with us today, we've got, we're fortunate, very fortunate to have one of the leading experts on the issue at hand today. I'll introduce him in just one sec, but before we get started, just a couple of housekeeping items. We think for you to have the best experience up here in the upper right-hand corner, if you're in a speaker view, that would be helpful. And I want to let you all know on the line, there's a Q&A button down at the bottom of your Zoom screen that allows you to ask questions, and we'll open it up for questions, not during the conversation with Dr. Lipkin, but immediately following. So let me begin. Right now, we have the opportunity to speak to, again, as I mentioned, one of the leading and most internationally recognized authorities on the use of molecular methods for pathogen discovery. Dr. Lipkin has 30 years of experience in diagnostics, microbial discovery, and outbreak response. He's mentored and trained over 30 students and postdoctoral fellows, and leads a team of over 65 investigators, postdoctoral fellows, and research support staff in New York, and another 150 across the globe. He and his team implicated the West Nile virus as the cause of encephalitis epidemic in New York in 1999. They discovered and characterized more than 500 infectious agents, including Borna disease, West Nile virus, Lujo virus, and human rhinovirus C. Dr. Lipkin has assisted the World Health Organization and the People's Republic of China during the 2003 SARS outbreak, and currently advises the Kingdom of Saudi Arabia in addressing the challenge of MERS. Dr. Lipkin has been featured in the New York Times, the LA Times, Discover Magazine, Nature Magazine, and a list that goes on and on. He was the chief scientific consultant on the Soderbergh film Contagion, which, by the way, was filmed in my hometown, or partly here in Chicago, and is working on a new series for AMC channel. With that, I want to open it up to some questions. We're going to start with Dr. Lipkin. Thank you very much, by the way, for taking the time and joining us today and help us sort out some of the things that are on people's minds.
My pleasure.
So there's a couple of areas of interest to the group on the phone. Healthcare is number one, and within healthcare, there's diagnostics, there's testing, there's therapies and vaccines. We'd also like to take the conversation into the aspects related to the economy, and frankly, what does it mean for private client portfolios? But to begin, let's talk about your experience. You're just back from China. Can you share with us what it was like on the ground there during the recent COVID-19 epidemic, and how that relates or is different from your experience during the SARS epidemic in 2003?
So first of all, I apologize. I actually have COVID now myself, and I'm trying to get over it. It's a much more miserable experience than I anticipated. I think of myself as 28, and I guess I'm not. So when you approach our vintage, it's a little more difficult. So first, I first heard about this outbreak of pneumonia in mid-December, and I spoke to people at the CDC there who were investigating this, and they didn't really respond until the 31st, when I was told that it was a new coronavirus, but it wasn't particularly transmissible. And it didn't make a lot of sense to me. It wasn't that there was anything being held back, but it just didn't smell right. So I went to China and spent a week in Guangzhou and in Beijing. At that point, I was not able to get into Wuhan. If I'd gone, I would not have been able to come back for at least a month. So I decided to forgo that. But it became clear to me that the only way to succeed in containing this outbreak was going to be with very, very aggressive containment measures, which was in fact what they did. And I think quite successfully, and their experiment will be useful in directing what we do in terms of our own work. When I compare this with SARS in 2003, SARS was less contagious than this. We had these instances where there were individuals who were capable of releasing large amounts of virus. We never quite figured out what that was, but they did. And so one individual would be linked with many, many cases of subsequent disease. And in some cases, we would have satellites, and those satellites would be restricted to just a couple of places: Singapore, Hong Kong, Toronto, We never really had much in the United States at all, but you didn't have the successful seeding of new communities of infections you have now with the new SARS-CoV-2. This is a very, very different virus. It is the most contagious virus that I've ever encountered. It's extraordinarily hardy. It can subsist on surfaces for up to 3 days, so that when people talk about this concept, and we use it in the movie, we talk about an R naught, the idea that, you know, one person infects 2 people, it's called an R naught of 2, or 3 people becomes an R naught of 3, and so forth. People keep talking about the R naught of this virus as though they know what it is. And my sense is that it's larger than we anticipate. And that's because this virus is so contagious, and because it lasts on surfaces, you don't have to have this kind of direct patient, person-to-person contact that we had really with SARS. There was some fomite transmission with SARS, but this is much, much more aggressive. And of course, we have a pandemic. We knew we had a pandemic for a long time before it was declared, but there's a resistance to declaring pandemics because of the implications, I think, for travel and for trade. The Chinese government has this under control at this point. In fact, I will say that when I came back, I was asked by the Chinese consulate in New York to come down to, they're on the west side, sort of fairly down to the bottom of the island, to give them advice on how not to get infected in New York. So when we were worried about people returning from China, they were far more worried about becoming infected in New York. And in retrospect, you know, they were correct. I mean, it's much more dangerous to travel through New York than it was to travel through China. And it's interesting, when I went through China, you would see everyone was wearing masks, even where there was an active infection. People wore gloves. You could not get into stores. They'd shut most hotels. And as a result, there wasn't a lot of spread after there was a decision made that they were going to take this very seriously. Because there are no drugs and there are no vaccines. So what we have is what we call social distancing, which some people call quarantine and some people call isolation. And there's a paper that came out today in Science, which specifically looks at the issue of how the virus moved around the world. And it's clearly human-to-human transmission, and it's community-based. And the most successful tool for combating it, as shown in this very careful analysis, is in fact, you know, things like closing borders or closing houses or closing hotels or amusement parks, whatever the case may be. They did this very early on, and we haven't, and the Italians didn't. And as a result, you know, we've had all sorts of problems they don't have. When you look in Germany or in Switzerland, where there was very aggressive testing from the get-go and very strict isolation procedures, their mortality rate and their attack rate is much, much lower than we are. So even if you took China out of the equation and forgot about whether or not they did right or didn't, you look at the model in Europe, those countries where people were vigorous about containment in the north have been successful, and those that are in the south, like Spain and Italy and France to some extent as well, have not. So I think that the lesson there is very clear in terms of what we can do in the short term.
Dr. Lipkin, that one of the things that has been of great concern is the fact that we don't have enough data yet. That is, perhaps we were a little slow here in the United States to get testing together. But in the last week or so, companies like Roche and together producing test kits and LabCorp and Quest Diagnostics have ramped up tremendously, it appears to me. And my understanding in hearing the CEOs of Roche and Quest Diagnostics speak, that in the next 2 to 3 weeks, they should be on producing enough tests and getting enough test kits out there. There's also, of course, the logistical hurdles. You don't just need test kits, you need somebody to administer them, and then you need somebody to deliver those tests to a lab, and you need somebody to turn the lab around with the results, and then you need to find those folks, track them, and isolate them if necessary. The first point of that equation is you need the test kits and you need the diagnostic capabilities. What would you say are where we are in terms of the innings, if it were a baseball game, in terms of being up to speed on getting enough testing done for you to be comfortable that we're getting a handle on this?
Well, the problem is that testing would have been much more important and much more helpful earlier than it will be now. I mean, our challenge right now is that we know there's a stunning amount of infection all across the United States. So as we test, we'll find that there are more and more people that are infected, but it's not at a stage now where we can contain it. So when testing is really helpful is when you have a nucleus of people who are infected, and you then go testing all around them and all their contacts and such, and it's a small enough number of tests that you can actually identify people and isolate them. But right now, there's so much infection. There are hundreds of thousands of people infected everywhere. So the testing the problem is, I think we're already past the point where testing is going to have a major impact on the course of this outbreak. It's welcome to have it, and I think it's important that we have it, but I don't think that's our solution. Now, you mentioned, what are the key issues with tests? What we're bringing on now are these molecular tests, which are useful for trying to identify people who are currently infected. Mm-hmm. We need to figure out who has been infected and who is immune. Presumably, based on analogy to other types of infections, once you've had this, you're not going to get it again, at least not this year, and probably never again. And the reason I say that is that the evolutionary studies of the virus thus far do not show that it's evolving and mutating like flu does, so that every year you would have to have a new vaccine. We think the protection is likely to last for some time. If we had some idea as to who'd already been exposed and who is immune, we might be able to say to those people who are immune, you don't need to worry. You're the right people to be you can go back to work. We don't have to worry about you. And we could focus our vaccine efforts on those people who've not been exposed. So when vaccines are in short supply, that may be useful. If we're trying to decide who should be a first responder, or who can go back into the population and initiate factories and air traffic controllers and everything else, those would be people we'd like to know about. So the next phase of testing is really going to include not only the direct detection, molecular testing, but in addition, serology to see who's been exposed, who has recovered.
So moving away from then the testing and onto therapies, it appears that there's a couple of different ways that you could go about attacking the disease currently. The folks at Regeneron, for example, have a two-step approach or a two-phase approach. The first one is trying to find something that's off the shelf, something like Kevzara or something like that. That is an RA drug, a rheumatoid arthritis drug that reduces inflammation. And I guess the indication there is if you can reduce the inflammation in the lungs, then the outcomes are much improved. So that's an off the shelf. But there's also other things that they're doing and other pharmaceutical companies are doing. That are trying to recreate the antibodies that would produce a virus infection type of a response that would be similar, I would guess, to the effect of actually having a vaccine. Can you give us a little bit of understanding of where the therapies stand?
Sure. So I think you've done a good job of summarizing the different strategies you have. One works on host response and reducing what is thought to be what's called cytokine storm, or the inflammation that results in bystander damage. Mm-hmm. And it sounds very good on the face of it, and I don't mean to discount it entirely. But I also want to say that some of my colleagues who work in ICUs are very concerned about the potential for these therapies to actually cause damage through facilitating the overgrowth of bacteria, which might otherwise not be a problem in the ICU. There is some suggestion that some people who take these, who receive these drugs wind up having bacterial infections that are worse than they might otherwise be. So it's not a panacea.
Right.
The Chinese are giving what's called passive immunotherapy, which is, there are two ways of thinking about the immune system. One side, detects, whatever's wrong, whether it's a cancer cell or it's an infected cell. and the other side attacks it in some fashion. And there are two different types of cells involved with this. One produces antibodies, which are these soluble molecules which target the virus and prevent it from entering cells. The other part of the system is the T cell, and the T cell actually attacks infected cells. So you need to have both really working in concert, one sort of dealing with the extracellular virus and one with the intracellular virus, to truly get clearance of the virus and what we refer to as a, as a real cure.
Mhm.
Now, you don't get that with passive immunotherapy. We are very bullish on passive immunotherapy based on antibody responses. And there are cocktails that were developed, for example, for Ebola and for other viral infections as well, that have worked to some extent. The time frame for getting these things designed, manufactured, tested for safety and efficacy is very long. During the interim, the only thing that really makes sense is to go back to the original approaches, which date back really to the very, very late 1800s. And that was the first sort of approach for developing a diphtheria antitoxin, which is convalescent plasma. And the FDA is approving the use of convalescent plasma for this in various trials and compassionate use and so forth. And the idea here is that you find individuals who've recovered from COVID, you check to make sure that they're not still actively shedding virus, you check their antibody titers, you see whether or not they will neutralize the virus. And I feel it's very important to demonstrate that it actually neutralizes the virus, not just some surrogate. And then you give a plasma infusion to somebody after first ensuring that the plasma doesn't have something else which might be dangerous in it. So you need to test it like any other blood product. Make sure there's no HIV, no hepatitis C, no hepatitis B, no syphilis, West Nile, any of these other kinds of things. So after you've cleared it, then you give that to the individual and see whether or not, in fact, they improve. We think that this will be effective, certainly in prophylaxis, if you have close contact with somebody who's been infected. If you are in the early stages of infection, this will almost certainly work. The question is how effective it will be in somebody who already has some lung disease. And that's why we're doing double-blinded trials. And there's a large consortium of plasma centers and medical centers. The lead really in this has been somebody named Arturo Casadeval at Hopkins, a friend of mine, who's really doing a very good job of pulling together such a consortium. Columbia has its own consortium because we're a very large organization, and we've been asked to do this just within New York City and see what we can learn. And there are many other groups that are trying to do this as well, and we think this is going to be helpful. Now, in addition, you've got all these drugs. People always try to repurpose drugs because they've already been through FDA. We know something about their safety profiles. And then it's really primarily a function of, are there tweaks that need to be made? Can we learn anything about efficacy in a simple trial? Now, a few days ago, President Trump said that there was this drug that's used primarily for malaria and a number of autoimmune diseases that has value. And we don't know yet that it has value. There are groups in China who feel that it does. There's someone in Marseille who feels that it does, but we haven't seen what we think is an adequate blinded, double-blind trial to see whether or not, in fact, it is of value. And sometimes we've been misled. So maybe this drug, the trade name is Plaquenil, hydroxychloroquine or chloroquine, may in fact have value. And then there are the drugs that are more specific. There's the remdesivir trial, which is ongoing, and there are 2-3 other drugs that are directed against the polymerase that may actually have some value too. And at the end of the day, it may require a sort of a bespoke approach for people with early disease, moderately, who don't show much in the way of signs and symptoms, people who are at high risk, people who are in extremis in the ICU, and there we may need to use, the antibodies to IL-6 from Regeneron or someone else, and the plasma therapy or something similar, plus remdesivir, plus antibiotics. it's going to take a while to sort this one out.
Could you, when you say a while, it's probably difficult to estimate when not only the therapies that you've discussed might become widely available, but also when a vaccine might become widely available. I understand the folks at Moderna are working on that, and other pharmaceutical companies. They've started a phase 1 trial as of about a week ago, and the NIH dosed its first participant. Can you talk a little bit about, as best as you can, understanding that there's a great deal of uncertainty involved, I think it would be of interest to the folks on the line to know at least a vague estimate of a timeline for when both therapies and vaccines might be available.
Well, let's start with therapies. The double-blind trials that I'm referring to, and by double-blind, I mean neither the physician or the patient is aware of what the drug is. And I should say that all these trials are monitored by something called a data safety monitoring board. And the moment it becomes clear that there's either an advantage or a disadvantage to one arm or the other of the trial, they make a decision to stop the trial and they focus so that everybody gets the benefit. I mean, we realize that when you do these trials, people want to be in the arm that's going to be getting the drug. But again, we don't really know if it's going to be helpful or not. So we try to make course corrections as they become apparent. I think we will know about the prophylaxis trials with hydroxychloroquine and with very, very quickly. I think that'll be a matter of 4 to 6 weeks from the time that begins, because our endpoint really is whether or not somebody who's been exposed winds up getting disease or doesn't. Mm-hmm. For the plasma trials, we still have to collect the convalescent plasma. And we have more and more patients who could be donors. And I would encourage any of you who are fit and capable of doing this, who recovered, to volunteer for a trial near you so that you can enable some of your community members to get access to these. But that's going to take us a while because we have to qualify all those donors. We have to look at their plasma. We have to make sure they have high quality antibodies, high titer antibodies, before we then use them for the trial. So those data probably won't come for about 3 months, but that's still going to be much faster than any of these sort of recombinant monoclonal antibodies that may be made by other companies. Regeneron is one of those. Now, with respect to vaccines, excuse me, I'm sorry. With respect to vaccines, the easiest part of making a vaccine, right, is designing the vaccine, with the exception of flu and HIV, where it's more difficult to make predictions about where we need to be. Once you have what you think is a good candidate vaccine, you do what's known as a phase 1 trial. The phase 1 trial is less than 100 people, and it's a safety trial. And what it does is it allows you to see whether or not there are going to be any immediately obvious deleterious effects of taking the vaccine. If you pass that first hurdle, then you've got the second phase. In the second phase, we test efficacy. Now, this takes hundreds of people, particularly in a situation where you can't challenge somebody with a drug or a virus, because then you're going to make them sick. So what we have to do is identify a natural experiment, someplace where there's an ongoing epidemic, and then you come into that ongoing epidemic and you give the vaccine and you see whether or not it has an impact on the incidence of that disease after they get the vaccine. Well, that makes a prediction, and you're never going to get a situation where 100% of people are going to become infected. So it takes larger numbers to sort of demonstrate some sort of efficacy. There are some surrogates we look for. Do they develop antibodies and so on? But that's not equivalent to protection. And that takes months. And then you have to do the phase 3. The phase 3 is both safety and efficacy, but it looks at the long-term effects as much as is practical of taking the vaccine. So by the time you get through phase 1, phase 2, phase 3, which is essential to demonstrate the safety and the efficacy of the vaccine, you're up at that 16 to 18 month window that the director of NIAID, Tony Fauci, talks about. I mean, there is no way to shortcut that. If there were, we would take it.
Yeah, my understanding from what I've read and an analysis of how the process is working is that it is in much accelerated mode. That is, it's been an unprecedented coming together of both business, private business, and the government to try and get a handle on this thing, in large part because of many of the things that you've said, Dr. Lipkin, and especially related to the contagious nature of the disease. We don't know what the R naught is yet, but you could guess that it's kind of in the, certainly not in a good area.
I don't think it's 2 to 3. I think it's much higher than that.
And that would compare relatively unfavorably, similar to HIV, I guess, is about 4. SARS maybe a little less than SARS or more than SARS. I can't recall.
A little less than SARS, but these are not meaningful. It's a very catchy term,
Yep.
and we stuck it in the film because it sounded really cool.
Right.
But the fact is, what really matters is how many people are getting sick, and how do we contain the outbreak? So everything is operating on an accelerated timescale, and what's driving that accelerated timescale is the following. Even if you have a disease, an infection, which has a low mortality rate, if you have a large number of people who are infected, the number of people who die is very, very high. So the mortality rate with, we really don't know what it is for this virus. And the reason is we have a lot of asymptomatic infection that goes undetected. So it wouldn't surprise me if the actual mortality rate were far less than 1. But that doesn't matter if you infect 9 billion people. That's a lot of deaths, right? So this is what's driving this urgency. The other thing, of course, is that the burden on the healthcare system is difficult to fathom. I mean, we are full. You know, our hospitals are jammed, and the ICUs are jammed, and we don't have enough ventilators. And people who have other medical conditions that require intense support or just even hospitalization at all can't get access to what they need if they have trauma or cardiovascular disease or some other infectious disease. You know, we have 40,000 people who die every year of influenza too, right? So that, you know, so this is superimposed on that normal respiratory death challenge that we have in the United States. So this is a big, big problem. And of course, the economic consequences have also been devastating.
Yeah, and I want to go to discuss both the economic consequences and what both the Federal Reserve, from a monetary policy perspective, and the administration and Congress from a fiscal stimulus perspective are doing to mitigate the economic damage. But I just want to dig just a little bit deeper into the state of the healthcare system here in the United States, because I think if there's an advertisement to continue social distancing beyond perhaps the original March, I think 15th date, and even beyond perhaps Easter, which is April 12th, the date that the president has suggested might be a time for us all to come back together. Of course, that's all data dependent, and you can't make a decision on that until you've got an understanding that the curve is being bent over. That is, the number of new cases is finally subsiding. In the meantime, though, you've got this concern that the number of respirators, the number of ICU beds, and other PPEs for healthcare workers or protective equipment and masks and things of that nature are inadequate. And in fact, we've heard from the president of Mass General, Dr. Peter Slavin, who suggested that we might be bumping up against the constraints fairly quickly. That's the advertisement for social distancing and to continue social distancing until you can get a handle on this thing, at least those that are at the highest risk. So a couple things. How would you characterize how the U.S. is currently prepared as it relates to the trajectory of the disease? And is there scope for getting at least some lower risk categories of citizens, either in pockets or by age or by other risk factors, back to work in the coming weeks that might be able to ameliorate some of the damage to the U.S. economy?
An interesting series of questions. So if we look at New York, where I just reviewed today some projections over the next 2 months, and because we have the largest concentration of cases in the United States at present, um, depending on whether or not we have, the status quo in terms of our, isolation, or we move on to say 20 to 30% isolation, or we go better 30 to 50% isolation, we will peak anywhere from 2 weeks to 6 weeks from present day in terms of the number of cases that are coming into the healthcare system, the number of hospital beds that are occupied in ICU, and so forth. That doesn't mean that after that we're out of the woods. That simply means we will crest, and that's when we expect our maximal challenge. That's in New York. In other places, it'll be different. And the fact is that if we were to just hunker down and say, this is what we're going to do nationally, everybody's going to go indoors. We're going to deprive this parasite of its, of access, to what it needs to grow. We could get through this whole thing in 6 weeks and be done. But that requires, an agreement, at the federal level to do that. And we don't have that. We have some governors who are being very strict about it. Some mayors are being very strict about it, and others who aren't. You can't do this in a haphazard fashion. And so because we're not doing that, the curve may flatten a bit, but it's not what we need to do.
Mm-hmm.
What's been shown is that the best way to flatten this curve and basically bring it down to zip is to say, move everybody indoors, full stop, and then do testing. And that's where the testing again comes in. Identify people who are isolated within groups, figure out who's infected, who's potentially infectable, and separate them again so that the people who are infected are restricted and can't infect anybody else, including the people who were thought to be at risk. And then you get a really flat curve. And at that point, once those other people get past that 2-week interval, you're done. You can control it. There may be little sporadic outbreaks here and there, but you'll be able to control it. And we should have done this when I first came back from China. We talked about this, even while I was there the very last week of January, but nobody wanted to do it. And the Chinese have really, as I said, they realized, they listened to their scientists, and they got ahead of the curve. We've not been doing that here. So in Tony Fauci, just to follow through one thing, in Tony Fauci, we have a world treasure. He's serious. He knows what he's talking about, and we should be listening to him.
So from just a layperson's perspective, I think back to 2 weeks ago, and it seems like a completely different world. That is, I can recall the moment that this became very real to us here in a liberal democracy, as opposed to a more authoritarian governmental situation where social distancing can be imposed perhaps more quickly. Yes, we could have or should have, but it wasn't until the day that they frankly canceled the NBA season, and I wasn't going to get to see a Blackhawks game 2 days later, that it sort of struck me that this is real now, and bringing the kids home, and we're all going to hunker down and we're going to do what we can, because it does feel a little bit like a war. And if that's the case, we've got the economic wherewithal to win this war. And if I'm not mistaken, we've got the right spirit here in the United States, if we can all get behind it, to do what's necessary to knock this thing down. That is what I hope for every single day, because as it relates to the economy, it has been difficult. We're going to see in the first quarter a significant slowdown, and in the second quarter of 2020, single quarter-on-quarter annualized slowdown in U.S. economic growth in the post-World War II history by a good measure. And it's unfortunate. It's unfortunate that what it takes to cure and to knock down the coronavirus outbreak is actually causing the U.S. economy to have a heart attack itself. But the way we are thinking about it, at least at Beacon Point, is that there's a game plan to be considering here, and the game plan is we got to bend the curve first. You have to knock down the number of new cases so that you can start to let people get back to work. And in the meantime, you're going to tote up the economic damage. That's the negative. But you're going to measure it against what the government's mitigation efforts are and the effect of the government's mitigation efforts. And I want to be clear. I'm an economist, and my understanding of having watched the Fed now for almost 30 years is that, well, you tote up what they've done, which is almost $4 trillion. If the Fed's balance sheet isn't at 7 or 8 trillion, up from 4.3 trillion 3 weeks ago, it's going to 5.5 trillion next week. It'll be at 7 or 8 trillion in short order. That type of liquidity provision is very meaningful and will create the types of conditions here in the United States that will allow the normal financial transmission mechanisms and credit provision to get us back up to speed faster than if the Fed didn't do what it was doing. And we're still waiting on a vote for the fiscal stimulus plan. But Dr. Lipkin, in that plan, there is at least 100 billion, maybe more, for hospitals, for the types of masks that are necessary and PPEs. Hopefully, that actually came a week and a half ago on March 6th when we did the phase 1. So there's a lot of I want to say support and stimulus coming, but it's still going to be very difficult. And from what I'm hearing you say, it's until we can get, it's going to be weeks at least, perhaps the month of, into April for sure, before we can start bringing all of those resources to mitigate not just the number of new cases. You got to contain the outbreak, and then you got to contain the damage to the economy. And one has to come. They can both happen simultaneously. Do you have any views about sort of whether or not the balancing the necessary social distancing is worth it to versus what's happening in the U.S. economy and what's likely to happen to the unemployment rate here in the United States? Any thoughts or comments?
So, Michael, that's a very rigorous analysis, and I'm not an economist. You're a doctor of the economy, and I'm a doctor of the human body. So it's and I think in terms of large populations and what's effective there, and I have to say that the major challenge we have right now is in getting this under control by preventing contamination of people by one another. And the only way to do that until we have a vaccine is with this distancing approach. And we're ultimately going to have to do it. And I keep saying over and over again, the sooner we do it, the less painful it's going to be. But ultimately, we're going to have to do this. Mm-hmm. So I know that the president would like to see this all over by Easter. I don't think that's going to happen. I hope I'm wrong. But what I do see is that there are some things that might allow us to get people back into the manufacturing sector and the service sector more rapidly. So if we do serological testing and we find groups of people who are seropositive, who are not shedding virus, we know that these are individuals who can't be reinfected. If we can, and we're getting more and more data on this all the time. But assuming that supposition is correct, then those people will probably be able to go back to work. They're still going to have to be very careful that they're not bringing something home with them that's infected. So that's going to be tricky, but maybe we can get something going in that fashion. The other thing is that there's going to be more and more emphasis, I think, in various sorts of prophylactic measures that will allow us to perhaps protect people who are exposed from getting infected. One of these things may be this plasma therapy. If we can get enough units of that may be helpful. But a lot of these things depend on all sorts of moving parts, and it's unclear how they're all going to come together. So the focus really has to be on this issue of containment for the present. And the sooner we can get that done, the sooner you can take care of, ministering to the economy.
Yeah, and that's, we've discussed how the Federal Reserve is generally the first responder as it relates to the difficulties in the economy, and they have really come ready to bring out the big guns. It's actually, I'm having a difficult time finding a superlative that captures exactly what they've done, especially with the move just as recently as Monday of this week. But going through the litany of what I would call the crisis playbook, which they developed in 2008 and 2009, and basically just needed to dust off the shelf. The thing about that's different in the economy about this and in markets about this event is it appears that this is going to be something that we can address fairly quickly, both from monetary and fiscal policy. And the fiscal stimulus plan, which is, by the way, currently scoped out at about 10% of U.S. GDP, seems like it should be sufficient. And more to the point, both the administration and Congress have said, look, if it's not enough, we're going to come back and we'll do more, which is really encouraging. Markets have responded. The last 2 days, of course, have been pretty good days in the stock market for clients. I would say, and again, I think you've laid out a very thoughtful game plan for what needs to be done in terms of we really do have to go ahead and do some pretty serious damage to the economy to stop the virus and then make sure that's job one, make sure that gets done. And the government is absolutely doing everything they possibly can, both from a fiscal and monetary perspective, to provide support to workers, to the businesses and the industries that are particularly effective, airlines, cruises, hotels, et cetera. So it's really quite impressive, the litany of support programs that have come out of both this fiscal bill in a bipartisan fashion. You only hear the nonsense on CNN or MSNBC or even CNBC, but they really have come together. The people that I've talked to in Washington D.C., especially a week ago when it first started, were very impressed with the both parties' ability to come together on this, and they should. It is an incredible crisis. But
you guys have one advantage that we don't in medicine and science. You have a Fed, which is relatively independent. We don't have anything like that in health and human services. So, we have to sort of stand there with our representatives and hope we're heard. And it's tricky. But I will tell you that the leadership right now at CDC and at NIH and, the president's task force is first class. There's no question about that. But they have to have the ability to make decisions, and they don't. They're purely advisory.
I would say this: the Federal Reserve, in its most recent actions, is actually providing support to all forms of private businesses that are deeply involved in the fight against, to find and the war on COVID-19 and the coronavirus. In terms of anybody that's a debt issuer, Regeneron, all the pharmas, all the big pharmas are large debt issuers. So what I would say is, no, there isn't a Fed that can directly go into the marketplace and help, but at least on the edges, they are supporting the credit function and keeping those companies, the lifeblood of the financial side of the companies moving, so the lifeblood of the R&D can continue to move forward and develop the therapies and vaccines that are absolutely necessary. I'm hopeful because of what I've seen, at least on the political side and on the economic side. And while what you've described, and I'd love to hear what you think about sort of how we get to the light at the end of the tunnel and what else needs to be done. And if you think that there is other strategies that the government or the pharma industry or that academia or frankly the NIH or the CDC should be pursuing, what is your prescription going forward? What's being done right? What's being done? What can be done better in your opinion?
So there's one thing that I can, well, there are a few things I could say, but the one thing I want to say that we're not talking about right now is how we make sure this never happens again, right? How can we prevent this in future? And the explanation for that really goes back to an international health regulation that was set up by the UN as an aspirational goal in 2005. And that said that every nation state in the United Nations should be fully committed to being able to document infectious diseases within its own borders and being transparent with the world community about that. There's an organization that we've tried to build called Gideon, which stands for the Global Infectious Disease Epidemiology Network, Gideon. That, and if anybody wants to know about that, they can write to me. This is designed to provide insights, infrastructure to the developing world for everything from influenza to sexually transmitted diseases to things like this, with the proviso that anything that they find has to be posted onto a common database. Everyone has access to that database. Anybody contributes to that database shares whatever IP might accrue, and that this will make us a safer place because it's going to be a global immune system. So I heard about this problem in China in December 15th. Now, Gideon was not in place at that point. The guy who was going to be part of this network told me about it. But if in fact, if this thing had been funded, he would have posted the sequencing data and everybody would have found out about this new coronavirus no later than the 31st of December of 2019. Now, it doesn't sound like 15, 20 years ago, some would say a month doesn't make any difference. But we know this is very different because, as you said, what was it, 2 weeks ago, you thought you were going to be going to, Blackhawks games, right? So in this new world with rapid movement of people across borders, we have to know immediately. So we need this program, and it's cheap. It's like $10 million a year. So when you put that up against the trillions of dollars that's being invested in this, it isn't even a drop in the bucket. It's less. So this is a program that should be funded, and it's decentralized, and it'll make a huge difference. We won't have this again.
I'll be honest.
That's the kind of thing we need to do.
That's a good policy prescription. I would say that from an investor's perspective, that's a great return on your investment, a great ROI to spend 10 million to save $1 trillion. I'd like to see more investments, quite frankly, that had that high of a return on investment. We've got about 10 or 11 minutes left. There's some questions that have been coming in from the chats. Do you mind if I ask you a few that have?
I'm happy to address as many as you wish.
Okay, so I'm thinking there's a lot of folks asking about supplements, vitamin C, other ways to sort of, I guess I would put it under the broader heading of boosting the immune system. Any of those have any efficacy? Any thoughts or comments on taking zinc, vitamin D, vitamin E, vitamin C, et cetera?
I have no objection to people taking vitamin supplements as long as they don't take them to excess. I'm also not aware of any evidence that unless you have a vitamin deficiency that they make any difference. But with anything we do, if there's a, I don't want to call it a placebo effect because that sounds pejorative, but if it makes you feel better, why not do it?
Got it. Other questions that are coming in relate to the durability of the protection. That is, once you've had it, can you get it again? There's some concern that maybe the virus doesn't have the same kind of durability of immunity that other viruses or other flus have. What are your thoughts on the durability of the immunity?
We don't have any direct evidence for or against that yet. I don't think it's going to be a challenge, however. People do seem to have neutralizing antibodies directly against this virus, and I'm sure they have T-cell responses as well. There are some animal model studies in non-human primates that suggest that you cannot be reinfected. This is work done with rhesus macaques. Mm-hmm. But until we have more experience, we won't know for sure. I speculate that we're going to have enduring immunity for at least several months and probably much longer.
There are other questions related to, and under the heading of, what other things can you do to protect your lungs in an environment like this? So living in high areas of high pollution, vaping, smoking, things of that nature, all of those things, I would suggest, based on everything I've read, and I'm thinking you're probably going to agree, you want to minimize those things at all possible because it does create a higher risk factor. Is that true?
That's true. I mean, you have these, the cells that go all the way down your respiratory tract. They have these little feather-like projections or hair-like projections called cilia that bring things that you inhale back up to the top and keep it clean of bacteria and so on. And smoking kills those. And as a result, you have more and more difficulty with lung problems as you get older. So yes, lung pollution is a problem. I'll tell you, when I was in China, first time I saw the sun in Beijing, as beautiful as, and blue skies and everything else, was when they shut everything down.
Yeah,
All the industry shut down. It was really quite remarkable.
it's
And you
amazing.
can see there's no pollution anymore in Chicago or New York.
If there is a silver lining to the shutdown of economic activity, it might be that, at least for a short period of time.
And climate change as well.
Yeah, exactly. Um, Trying to combine a few questions. What's being done? Oh, well, here's some client-related questions. What should clients be doing in an environment like this? And maybe I'll start by making a couple of comments. It's a very difficult time to say to a client right now that they should be taking on a substantial additional amount of risk. But given a lot of factors that are in play in today's investment environment, it does seem to make sense to at least start to do a couple of maybe proactive things. One, it's always a good thing to rebalance, and we've talked a lot about that at Beacon Point, because when the recovery comes, you've already found yourself with a more conservative portfolio given the decline in equity. So if you started with a 60-40 portfolio, you're at the lows, you were at a 52-48 portfolio because of the decline on the equity side. Other things that we've been talking about for clients, if there's cash to be invested, and I wouldn't necessarily sell risky assets out of the portfolio. And by the way, before I say any more, I have to say, talk to your client advisor. Every situation is different. Everybody has a different risk approach. Everybody has a different utility for both risk and risk aversion. So please talk to your client advisors. But on a broadly speaking, and in very general terms, the markets are dislocated. There are things that have happened in credit markets in particular. And when I say credit, think investment grade corporate bonds and municipal, state and local municipalities, which are, by the way, on the front lines of the efforts to contain the coronavirus. So state and local, you knew the state and local communities and the debt that supports them were going to be supported by the government because they're the healthcare system, the educational system, which is obviously shut down, but the cities and the states are the front lines of the fight to contain coronavirus. So there has been, because of a general lack of liquidity in the marketplace, a reversion of credit, which, by the way, and I was around and trading credit portfolios in 2008 and 2009. There are some very similar features. There's a lot of differences, but there's a lot of very similar features to what happened in 2008 and 2009. So for most clients, I would say it's not a good time to sell riskier assets because the government's cavalry is coming to the rescue. That is, the government is making every effort to put a floor under the damage to the economy, which is what is going to help soothe the markets. You've seen it in the last 2 trading days. I don't think this is the end, by the way. I don't. So this has been the most uncertain period of time in my investing career because we've never seen a sudden stop of the US economy. I used to manage emerging market corporate debt, and you saw sudden stops in places, frankly, in emerging, like not quite in Brazil, but in Argentina, Venezuela, et cetera, and other places. Those are the kind of countries that you see economic sudden stops. Here we're having one in the United States for the first time. So it's very uncertain, but dislocated markets where the government is providing support seems to be a pretty good spot for clients to start thinking about doing something with any cash that they've included in their portfolios. I'm going to look through here and see if there's anything else, Dr. Lipkin, that might be, surprisingly, all of the healthcare related questions were at the front end. And now, okay, so Dr. Lipkin, do certain behaviors set back our progress? So what should people not be doing? Is there some final thoughts or words that you might want to leave with the folks on the line today? I think you've made a great case for social distancing and for self-quarantining, and that the more rigorous, the better. But is there anything else that that we should be doing behaviorally to help in this fight that we're going to be in for at least a few more weeks and maybe a month, that we can do to get this behind us as quickly as possible?
The only other thing I always tell people, because it's useful for this and for Alzheimer's and a whole series of other things, is get exercise.
Yeah.
It's the best way to keep your immune system intact, prevents you from getting, developing type 1 diabetes or becoming overweight or any of the other things which are also contributing factors, and it'll ward off depression. So get exercise somewhere or another.
That
Peloton is a great source. I use it all the time.
that's great advice, spectacular advice. And I think all of us on the call today, I've seen several messages here saying, please, Dr. Lipkin, take care of yourself and get well as soon as you possibly can. We need folks like you out there finding what's the solutions to this problem. World-renowned virus hunters like you are the ones that keep us safe in the long run. So thank you again for all that you do and for taking the time.
Thank you.
I want to thank everybody who's on the call today for attending. We appreciate your time. We really do. And we wish you and your family safety and good health as we navigate the unfolding COVID-19 crisis together, whether from the office or remotely via secure networks. Beacon Point is fully staffed. We stand ready to help in any way that we can. I want to thank all of you again who are on the line with us today for the confidence that you have placed in us as your advisor. And with that, we're going to close the conference today. Again, my thanks to Dr. Ian Lipkin of Columbia for all of his help.
We'll do our virtual handshake.
Do a handshake, a virtual handshake. Thank you, Dr. Lipkin. You take care. Bye-bye now.